Assalamu alaikum.
Waalaikumsalam, Doktor.
How are you?
Alhamdulillah.
Alhamdulillah. Okay, so today we are going to discuss the issue of important practice about the procedures. Just remembering you that your hand and your professionality and your intervention is a very important for you. Okay. It may be we are going, inshallah, to put a lot of theoretical details, but my job is just to give you soft touch about the clinical hints over that, and preparing, inshallah, you to be able to practice, inshallah, soon. I think from the next week you should be around. Don't hesitate if you see any procedure or whatever looks simple to attend, because we have 3 levels. First to observe, second to help, third to do, and the fourth is teach the other. Okay, that is the cycle. Even they used it to say, see one, do one, teach one. They mean not one means single, but until you are able to do that. Okay. So let us start by الكتاب الفاتحة and start by the first presenter who is Adila Jasmine. Okay. بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم We need to close the camera because of the internet in the hospital. Sometimes may be interrupted. Okay. Go ahead.
So I will start first. Can you hear me?
Yes.
Okay. My name is Adila and I will start presenting on central line or central venous catheter. So the route for central venous access, there are several access, which include peripheral inserted central catheter, femoral vein, internal jugular vein, and subclavian vein. But for today, I will focus on femoral vein. So femoral venous catheterization is used for diagnostic cardiac catheterization and intervention, and it is very commonly used by less experienced staff, especially as there is no major anatomical variation in the superficial femoral venous system, and incidence of severe complication related to the line insertion is low. So there are several indications for femoral venous catheterization. The first one is seriously ill ventilated pediatric patient, especially with difficult peripheral vein access. Second, to obtain central venous pressure. Third, longer term intravenous infusion. Fourth, hemodialysis. Fifth, the frequent blood sampling need to be performed. Six, emergency resuscitation is warranted. And seven, monitoring of central venous oxygen saturation and central venous pressure is indicated. Oh, before that, I'm sorry because I cannot open my video because the line is slow also here. Okay, so I proceed. The contraindication for femoral venous catheterization, absence of trained doctor, bleeding and clotting disorder, risk of contamination of the canalization site by urine, feces for femoral vein, infection, trauma, and distorted anatomy. So these are the list of equipment that are needed: sterile set, lidocaine, 1% for local anesthetic, syringe, 5 milliliter syringe and normal saline, T-connector and 3-way tap, Seldinger cannulation set, which includes syringe, needle, guide wire and catheter, and also sterile dressing. So the first step, we give analgesia and sedation, and in ventilated child, give a dose of analgesia and sedation, but I cannot find the dose that we give. Okay, after we give the analgesia, we position the child in supine position, expose the chosen leg and groin in slightly abducted position, And the pelvis is elevated slightly by placing a towel under the hips, as we can see in the picture. Okay, and then after positioning, we landmark. Identify the landmark by palpating the femoral artery pulse in the mid-inguinal region, and the femoral vein should be medial to the femoral artery. It is a 5 to 6 millimeter in infant, 10 to 15 millimeter in adolescent, and it is recommended to use ultrasound guidance for this procedure for better visualization. Okay, and then we can proceed with insertion. So we clean the inguinal region thoroughly using iodine and 70% alcohol using the swab, and then infiltrate local lidocaine at the proposed site of skin insertion. Insert the saline filled syringe and needle at 30-degree angle to the skin and parallel to the femoral artery pulsation. So the needle will enter the skin 2 to 3 centimeter below inguinal ligament and vein 1 to 2 centimeter below inguinal ligament, and will pull the plunger gently and advance superiorly in the line with the leg. So when there is a backflow of the blood into the syringe, stop the suction and disconnect the syringe from the needle. So this is the Seldinger technique. Okay, so the first one, as the blood is aspirated, disconnect the syringe from the needle. We can see the picture in the step 1. And then insert guide wire via the needle. The guide wire is then promptly and gently inserted into the needle. Withdraw the needle and make small incision on the skin and introduce the dilator. Okay, right here. And the catheter is positioned and remove the wire and check for easy backflow by gentle suction on the syringe. And secure catheter by suturing and ensure insertion site is clearly visible at all the time. So this picture is very clearly illustrate what I was talking about. Okay, so insert the needle and then place the needle in the lumen of vessel, and then insert the guide wire, remove the needle, thread the catheter, and then remove the guide wire. So this is another picture. Okay, so among complication, it can be divided into early complication and late complication for femoral venous catheterization. The first one is hematoma, hemorrhage, and then guide wire can cause embolism and also cardiac dysarrhythmia, particularly from high-lying central line. And for late complication, it includes central line associated bloodstream infection, phlebitis, thrombosis, and erosion or perforation. So these are my references. That is all for central venous line. So can I proceed to second part, doctor?
Anyone need to ask any question?
No question.
Okay, so if no question, I am going to ask. So, Shuhada, what is the meaning of Seldinger maneuver?
Sorry, doctor, I don't think we have any Shohada here.
Suliha, what I cannot.
Soleha.
Saliha.
Yeah.
But you make it Saliha by A, but she is by O. Okay, acceptable. To come from Arabic country until here can be changed. Suliha. Okay, Saliha.
Yeah.
What is the Seldinger?
Seldinger technique is a technique whereby the catheter over the guide wire technique, whereby we insert the guide wire first, and then we make an incision, then we introduce the dilator, then we insert the catheter over the guide wire, then we remove the guide wire.
Yeah, this is a very important one to introduce, because we are inserting simple cannula first to pick the vein or the artery, and then we are going to put this guide wire, and then we need to insert slightly big size cannula If we start by it on the start, it cannot pass. So you need to just do simple excision and pass this new catheter and then remove the wire. Very dangerous if you miss the wire and let it go inside the, the vein or artery, which is a central one, and you need to go for vascular surgeon urgent to remove it. So that's why we must be very cautious, okay? And know in every procedure what is the precaution which we must take, and don't be so hurry, okay? And don't feel overconfident. If you, even if you are very good, don't be overconfident. Otherwise, you can make a major mistake, which can be life-threatening to other, or it is a propaganda and a problem. Okay, so that is the issue. Any procedure related to the vessel, okay, we just need to define the vessel, whatever the vessel. Is it peripheral one? Is it central one? Is it BICC? Is it artery, vein, like that? It is very simple, inshallah. If some of you going to be a cardiac surgeon, you can also go for peripheral artery, and you can do also correction through the intervention radiology. So all these are very simple. So the starting point is how to define the vessel and try to break it by a good manner, so your cannula is resting comfortably inside it, so you can do whatever, to use it directly, to put cylinder and change by bigger size, to put the percutaneous line. So this is the starting point. And remember that the vein is better felt than seen. Sometimes you need to just look far from the vein and try to palpate like this. You will able to palpate. Okay, it is very important. Okay, you can continue now for
Okay,
the
so
second presentation. Okay.
I will continue with my second part. Okay, can you see the slide?
Yes.
Okay, so my second part would be catheter bladder drainage or CBD. So the indication for CBD are to obtain urine specimen to look for urinary tract infection, monitor urine output, relieve urinary retention, and for MCUG, mid to rating cystourethrogram, which patient may be needed to be given either a set dose of IV gentamicin or trimethoprim. So we give through CBD. And then the fifth one is to obtain urine specimen for microscopy or culture. The contraindication for CBD include traumatic injury to the lower urinary tract, major anatomical malformation of the lower urinary tract, and recurrent reconstruction of the urethra or bladder neck. So the equipment that are needed include dressing set, urinary catheter of appropriate size. We use 4 French for less than infant of less than 3 kilogram, or 6 French for children more than 3 kilogram of body weight. And older children, we use polycatheter of 6 to 10 French depending on the size. And then prepare some local analgesic or KY jelly for the lubrication, and syringe and water for injection. So we can divide the CBD technique in male children and female children. They differ because the anatomy is different, kan? So first, prepare, place the patient in a supine frog leg position, and using the gauze, wash the external genitalia with soap and water, and rinse with clean water and dry the skin. The third step is place the sterile urethral catheterization kit on a tray and open the inner paper wrapping to form a sterile film. Fourth step, lubricate the distal end of the catheter with sterile gel. And then we can proceed with the procedure. So after we have prepared the patient, prepare the entire genital area by cleansing 3 times, going from the center to the periphery. Okay, center to the periphery. using an antiseptic agent. We can use the povidone and then gently retract the foreskin, especially if the children is not circumcised, and instill some of the sterile lubricant gel into the urethra. Use 1 to 2 milliliter for neonates and infant and up to 5 milliliter for adolescent. Allow 2 minutes before proceeding with the catheterization if the lidocaine gel was used for analgesia. Slowly insert the tip of the catheter into the urethral meatus with your dominant hand and then using your finger or forceps to advance it into the bladder. Secure the catheter with adhesive tape to the lower body and remove catheter after urine collection if the purpose is to obtain urine for microscopy and culture and sensitivity. Lastly, connect the catheter to the urine bag. And if the foreskin is present, gently pull it back over the glands to prevent the development of paraphimosis, which is the gangrene of the foreskin. So this is the picture. Put the baby in the frog position. Okay. Insert into the meatus like this in the picture. Okay, so in female children, the process is quite the same, except quite the same. Okay, after prepare the patient, baby prepare the genital area by cleansing the 3 times, also from the center to the periphery, and then place the sterile fenestrated drape over the patient so that the vulva is accessible through the opening. And we use thumb and index finger of non-dominant hand, separate the labia, which are considered to be non-sterile, and with dominant hand, use antiseptic soap sterile swab or povidone to wash the urethral meatus 3 times in the anterior to posterior direction, and lubricant gel is placed on the catheter before the procedure is performed. Use 2% lidocaine gel squeeze out above the vagina before the catheterization and we wait for 2 minutes. Once you have located the urethra, hold the lubricated catheter with finger of dominant hand and slowly and gently insert the tip of the catheter into the meatus and advance it into the bladder. So the other end of the catheter should remain in the container. After the catheter has entered the bladder, urine should drain through the container. And remove the catheter after urine collection if the purpose is to obtain urine for microscopy and culture and sensitivity, and connect the catheter to the urine bag. So this is the picture. We must understand the anatomy of the female genitalia to locate the meatus. So among complication, infection, gross or microscopic hematuria, urethral stricture, paraphimosis in male children, and frank fistula with urethral perforation. But this is a very rare complication. So that's all, and these are my references. So is there any question from the floor?
Good. So this is an important one, which guide us the importance of knowing the anatomy. Okay. Is very important to be able to do catheterization, especially in female, especially if it is a young girl. It is very important. It looks very simple if you know the anatomy good and be patient to pick the tip of the catheter. Okay. The other thing is sterilization. It is not non-negotiable thing. You must do any procedure under complete aseptic technique. You are not allowed, you must do like that. I used it to tell all of my students, if you are going to pray, you are going to wash your hand. Yes, this is an order from Allah. Wash your hand. Even in Islam, the Fuqaha said you must wash your hand and catch the water and make madmada and istinsha for mouth and nose, just to know if this water has no color, no odor, no smell or not. So you need to make sure that it is completely sterile. So you will wash your hand and put in the mouth, no odor, no taste, put in the nose, no odor. So it is completely sterile. You can go for washing the face and the upper arm and the hair and the leg like that. This is the same. Allah asks us to give anyone benefit and don't harm him. We are not allowed to cause harm. If you are not doing a good sterilization, then you just insert peripheral cannula, the patient will get thrombophlebitis. If you insert it in the central line, your Adila spoke about the central line infection, class B. It is very dangerous because you are putting bacteria in the blood in the central line, which is very dangerous. Okay, so this is the most important. Please take care about that. Okay, don't ignore the importance of sterilization, even it will take some time from you and make it bit difficult, but this is Islamic rule. No way to cause harm for anyone. Sometimes you are not able to give benefit. You cannot, but don't cause harm. Okay, thank you. Second presentation.
Alright. Data section.
Yeah, you can increase your volume.
Alright, so Bismillahirrahmanirrahim. Can you hear me clearly?
Yes.
Alright, so for my part, I'll be presenting on ECG and also EEG. So first we'll start with ECG first. Next, please. Okay, so what is ECG? Like we all know, ECG stands for electrocardiography, in which we place electrode on the patient bone, on your patient's skin to detect the electrical activity of the heart. And then this way we can detect an abnormality in the heart. So if in adult, the usual indication for ECG is usually chest pain, but chest pain is quite an uncommon uncommon complaint in peds. So what is the indication of ECG in peds? So we do ECG in the case of the children that has non-cardiac history or they have family history of sudden cardiac death. And also they can be done to the patient that presented with syncopal, cyanosis, dysthymia, or it can be tachyarrhythmia or bradyarrhythmia, and also in the case that we suspect for drug injection or other poisoning. So is there any complication in ECG? So generally, ECG is a safe procedure, and the only risk is that some children, they may have reaction to the adhesive used to put the electrode. Otherwise, it is a safe procedure. So next. So sorry for the disarrangement in the slide. So anyway, before we do ECG, we must prepare the patient first. So we first must verify the patient details. So we do this by asking the parent, or if it's an older children, we can ask the children themselves. So we ask their names and also their identification detail number. And then we must position the patient comfortably in supine position, and then we must remove the clothing adequately. For the younger children, we may require the cooperation of the parent or caregiver in order to make sure that the patient, they will stay still, because any movement will disturb the reading of the ECG later on. So for the limb, start with the limb leads. So similar to adult, we have 4 limb leads altogether. And then I think you can see in this picture, in our clinical setting, I think the color is usually red, yellow, green, and also black. So in this case, the red will be on the right upper limb, yellow will be in the left upper limb, and then for the left lower limb, the blue one is supposed to be the green one, and then for the black is black also in our setting. And then for the children, the difference is that we may place it in more proximal position, can be near the shoulder or hip, because we want less muscle artifact. Next. As for the precordial lead, so it's a bit different in terms of adult, because in younger children, their right ventricle is usually the right ventricle is extended to the right side of the sternum. That's why for the precordial lead, instead of B4, we have B4R, in which instead of putting it at the left side, we put it at the right side. but the position is the same. And then for the other leg, it's the same. So we start by palpating the sternal angle. So the intercostal space that is correspond to the sternal angle is correspond to the second intercostal space. So for the right side, we go down till the fourth intercostal space. That is the V1. And then for the left side, that is the V2. And then we're supposed to locate the V4, which is at the fifth intercostal space, but at the right mid clavicle line. This is supposed to be the position of the V4, but we didn't put there. We put at the left side. And the V3 is between V2 and also the V4. For the V5, it's at the same level of V4, but it at the anterior axillary line. So we'll usually put it at the where the rib curve to the back. And then for the V6, it's also at the same level of V4 and also V6, but it is at the mid axillary line. Usually it's below the armpit. So you can see the location more clearly based on that picture. So next. So as we know, this is about pediatric, right? So some children is usually very small, especially in the neonates. So it's usually not possible. It's maybe not difficult for us to measure the rib space. So instead of using the rib space, we replaced it by using the nipple line as our reference for the fourth intercostal space. So you can see the difference is basically the fourth intercostal, instead of palpating for the fourth intercostal space, we use the nipple line. So this is just a repetition of previously. So next. Okay, so for the, I will not go for the how we can interpret the ECG, because I think we have already learned how to interpret the ECG. So we can interpret for pediatric ECG, how to interpret it is the same as an adult. However, we must take note that some finding that we may find it abnormal in adult can be normal in pediatric, because they are a bit different. If so, for example, the normal heart rate in adult is 60 beats, 60 to 100 beats per minute, right? So, but if in pediatric, heart rate that is more than 100 beats per minute, it can be is normal, because as we all know, starting from the neonates until they become, the heart rate is much more than adults. And then for the right axis deviation, and also the dominant R wave, because as I mentioned before, the right ventricle in children, they are a bit displaced. This is mainly because the right ventricle is thicker at birth, and then progressively the left ventricle will become larger. So if it's in younger children, it is considered normal if the right axis deviation, there is right axis deviation, and this right axis deviation is usually resolved after about 6 months old. And then they may also have T-wave inversion in V1 and V3. And this condition, they may persist up to, I think, 6 years old. So this is, if they found any T-wave inversion, it is considered normal. And then if there any Q-wave in the inferior and left precordial, and also there will be shorter PR interval and also QRS complex in children because of the smaller cardiac size. So this is all from ECG part. Any question? If no question, may I proceed to EEG, doctor?
So they understood now? All of you understood how to do the EEG and how interpret it? Hello? So
Yes, doctor.
your colleague put some of the important domain you must be able to comment, like speaking about the rate, speaking about the rhythm, speak about the axis, speak about the dominant one, and then you must go for it part by part. I mean, what about the B wave? Is it left-sided or right-sided, increased or not increased? What about the VR interval? Then what about the QRS? Then about the T, and if it is there any strain or myocardial infarction? All this must be very clear to you. Is it clear? Or do you need to study it? You can just open short article. Simple how to interpret EEG. I think even internal medicine, many times they are bringing for you an OSCE, just a piece of EEG of a common myocardial infarction, heart block, like that. So it is very important to know. So I think you need Hanani to make this job. So your colleague know how to do the EEG, but I now need them how to interpret at their level as a 5 years student, which may be after very short time we find you in the emergency department or ever department working as there. Okay, you will do, or should I cut? Okay, Hanani?
InsyaAllah, Doctor.
Okay. If you finish, just update it to me also, okay?
Okay.
You can go for the next presentation.
So next, I'll be talking about EEG, the electroencephalogram. Next. So electroencephalogram is used to study the brain electrical activity. So it's an essential tool for seizure evaluation because, like Doctor have mentioned yesterday, that EEG is used to clarify the type of epilepsy type, and also we can use to localize the location of the seizure. And then other use include we can assess the degree of encephalopathy and sleep disorder, like we have learned in the psychiatric posture previously. And also, it can be used to determine the brain death. And then, similar to ECG, this is a safe procedure. And then we must explain to parents that we only measure the brain activity, that we do not transmit any sensation to the brain. And then we also need to mention to the parent that the seizure may be intentionally triggered in some patients, but it will be done under close monitoring. So next. So prior to the EEG, because we already, before we do the EEG, we must also getting the consent and also explain about the procedure. So before the day of the procedure, we must inform to the patient to wash their hair and scalp using shampoo, but they must avoid using any hair conditioner or the hair products such as hair gel or hair spray before the procedure. And then they also must avoid any food or drink that contain caffeine at 2 to 12 hours prior, because caffeine, it will affect the reading letter. But the patient should not fast the night before, because the hypoglycemia also can affect the result. And then if in the case that the patient, they are supposed to sleep during the EEG, they may be asked to sleep for shorter duration or not sleep at all in the night before the procedure day. So this is very important because this will help to determine the accuracy of the reading later on. So next. So the equipment of the EEG, we include the electrode, the amplifier, and also the EEG system. So the electrode, it can be similar to the ECG, in which we'll stick one by one to the head of the patient, or there is some that has a set of electrode altogether, so we just put it at the patient head as similar to the wearing head. And then for the amplifier, because the the electrode will detect the brain signal. However, the brain signal is usually very small, so we need the amplifier to enhance the brain signal. And then for the EEG system is where the amplified brain signal will be collected. And then this procedure, ideally it must be done in a quiet room with the controllable lighting level. Why controllable lighting level? Because as I mentioned before, in some patients, we want to induce the seizure, right? So we need the help of the lighting to do so. And then how we place the electrode is that we usually follow the international 10-20 system. So you can see in the picture below, the picture I've provided there. So it used the letter and also the numbering system. So for the letter, as you can see in the right picture I put, so the letter represent the location, the lobe where we put the electrode at. And then for the numbering, is basically determine the side of because the left side is odd number and then the right is even number. So it just determine, it will help us for the reading letter. So next. So EEG it will be interpreted by the neurologist. So how the neurologist will interpret, they will look at the overall pattern and then they will detect whether there is any problem in the particular area. So the trained neurologist, they will able to determine whether this is what type of seizure or whether this is a normal brain form. So just a little bit about the waveform that we can found in EEG. And then, so there is several type of waveform that is determined based on the frequency. So starting from the lowest frequency, which is delta. So this is usually occur during the sleep phase. And then there is theta, alpha. Alpha is when patient is in the resting position. And for the beta, then they continue delta, theta, alpha, and beta is when patient is getting ready to wake up, but they haven't woke up yet. And the gamma is when patient is paying attention. So this just a brief about the EEG because uh we I don't think it's really my level to teach how to interpret EEG because EEG will be interpreted by the neurologist. However, we can go to the next slide. So this is actually a normal EEG of an infant. I just want to highlight do you see the numbering at the left side? So this is correspond to the electrode that we put previously, the 10-20 system. So what I want to highlight here is that this is how we can determine where is the location of the epilepsy problem. Because because this is how we can determine the location. If it's involved all, maybe it's a generalized problem. So that is all for me. Next is my references.
Yeah.
I have question.
Yes.
What if in children with deformity, for example, in patient with hydrocephalus, is there any difference in the placement of the electrode, or is it the
I
same?
because if it's in the case of hydrocephalus, meaning that the lobe is all the scalp is still intact, right? So maybe they will need to measure the exact location first. They will still put 10 to 20, but maybe the distance will be different as compared to the patient with normal head size.
Sorry, I cannot understand you. What do you mean?
I think because Adila asked whether there is any difference in the placement of electrode in the case of patient with hydrocephalus. So for my reading, I think it will still be the same, but the one performing the EEG, they must determine back how we can place the electrode, but they will still put the same number of electrode.
Yes. It is the same, but we'll adjust according to the size. Okay. Good. Okay. Any other question? So this is a very important presentation which guide us to the importance of something. If we didn't go through it, we're still afraid. Like you have one room inside the home, you are afraid of it. You will not open it at all because you feel that maybe something bad inside. It is not good. This way of thinking doesn't work with medicine. You must open all room in medicine. And if you open it once, everything is okay. I mean, this EEG, if you know the idea of EEG, and even the simple one, as we speak about the ECG, we need to know to speak about these 8 points which we need to comment on. Here also we must know how to comment, okay, about what the type of the spike, alpha or beta or theta or gamma or like that. Is there any convulsion spike? Is it unilateral or bilateral? And is it in the left side or the right side? All this can be answered, and you will find simple guide about the most common EEG, which is about 6 or 7 types of EEG. If you saw it, it is diagnostic. I mean, like absent 3 in second, okay? Absent seizure, Rolandic seizure, grand mal epilepsy, like that. So hips arrhythmia, which is the EEG is upside down of the thing. So there will be some common features which can guide us. Okay, so put it in your hand, please. If you find the chance to go through simple revision about that, I think it is not so common to be asked about, but I feel your days you have everything in your phone, everything in your thumb and finger. You can do it. So please, in spite of do and try most of the games, most of the songs, most of anything, try also to go through this thing, because with time you will find yourself in advance for others. If the patient came to you with ECG, you will get a look and the good impression, and then go for the, oh, I missed this one, so the next time you will be more better. But if you are completely blind, you will still blind. And this is not good, okay? Did you pick the point? Okay, thank you for your electricity, Hanani. Then we can go for the third presentation.
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Rosana Mutadawafid, and I will present on the integrated integration into electric as well as the intravenous stimulation. So first, the integrated integration into electric. The next slide. Okay, these are the indications for the EPP tube and general indications for EPP. The first one is the failure to maintain the air patency. Second is decreased consciousness and loss of airway reflexes. Next, failure to ventilate, then failure to oxygenate, and lastly, anticipated clinical cost or deterioration. Okay, next. Okay, regarding the contraindications, the contraindications are divided into two, the absolute contraindications and relative contraindications. Okay, absolute contraindications for EP tube are total upper airway obstruction and total loss of facial or oropharyngeal landmarks. The relative contraindications are anticipated difficult airway in which endotracheal intubation may be unsuccessful, or the crash airway in which the patient is in an arrest situation, unconscious and apneic. Okay, next. Okay, next is about the anatomical importance in unit. Okay, we need to mind that in unit, the airway positioning is quite different, whereby in unit and also pediatric units, they have short neck, and then they also have larger tongue compared to adult. They have angled vocal cords. They have differently shaped epiglottis. They have funnel shaped larynx with the different narrowest point. For example, in the cricut ring in neonate narrow compared to the adult. Yeah. And the trachea is short and flexible in neonate. And lastly, the nasal lymph tissue, which may prevent the nasal intubation. Okay, next. Okay, this pictures show the difference between the adult airway and also pediatric airway or child's airway. Okay, as you can see, there is larger tongue, and then the larynx is in a funnel shape, while in adult there is straight larynx. So this is the summary of the difference between adult and also child airway. Okay, next slide. This slide is about the equipment. Okay, the equipment needed for ET intubation are first back valve mask. The back valve mask must fit the nasal bridge and the chin of the patient without covering the eyes of the patient. Second is the glove. Next is endotracheal tube with stylet. Okay, mainly in pediatric, the uncuffed ET tube are indicated. So usually the uncuffed ET tube is needed in unit, infant also young children below the age of 8 years old. However, there is a randomized trial, a study, which stated that the cuff tube had better tidal volume and also less leakage compared to uncuffed. But it is suggested to use the uncuffed endotracheal tube for children below the age of 8 years old because the cricut is narrowest part of the airway. So the cuff are mainly unnecessary, and the cuff also may lead to tracheostomy. That's why in children we use uncuffed EP tube. There is a picture after this which shows the difference between the cuff and also uncuffed EP tube. Previous slide. Okay. Next is the suction system. The fifth equipment, laryngoscope and blade. Okay, as we know, there are two types of laryngoscope: the Miller or the straight blade, and also Macintosh, the curved blade. Okay, the choose uh the chosen the okay there are several anesthesiologists who use Macintosh or the curved blade in all children over the 1 year old, but there are some others anesthesiologists who will use the straight blade or the Miller blade until 5 years old patient. So it differs between the anesthesiologists. Okay, next is the 10 ml string if we use the cuff EP tube. Next is tape, and lastly the stethoscope or end-tidal carbon dioxide detector. Okay, the picture attached in this slide is about the checklist needed for the EP intubation. Okay, first we need to ensure the required personnel are present. Then we need to ensure that the rules are assigned to the staff. Then we need to meet and inform the parents about the procedure. And then we need to prepare the drugs because we need to sedate the patient. So the drugs needed are atropine, induction agent, and also neuromuscular agent. And then we prepare the EP equipment, intubation equipment. And lastly, after all have been prepared, then we can proceed with the intubation. Okay, next slide. Okay, this slide, the first picture where there is a and B. Okay, the straight blade is also known as Miller blade, and the curved blade is also known as the Macintosh blade. Okay, the second picture is about the tape, and then the picture below, that is the difference between the cuff and uncuff. As you can see, in the cuff ET tube, there is a balloon at the tip of the tube, while uncuffed, there is no balloon at the tip of the tube. And the table beside it is the diameter or the size of the ET tube needed according to the age. So we need to choose the proper size of ET tube and also proper laryngoscope, the size of the laryngoscope for intubation. Okay, next. Next is about the steps in performing AET intubation. First, we need to place the patient into a sniffing position, if not contraindicated. Then we need to pre-oxygenate the patient for at least 3 minutes prior to intubation in order to denitrogenize the lung. And then we need an assistant to apply the Sellick maneuver. Okay, Sellick maneuver is the maneuver whereby there is application of pressure to the cricoid cartilage at the neck, thus occluding the esophagus, which passes directly behind it. Because we need to prevent the aspiration. The fourth step is we need to hold the laryngoscope in our left hand with the blade down, and then we open the patient's mouth with our right hand. We insert the laryngoscope blade to the right of the patient's tongue. Then we gradually move the blade into the center of the mouth and pushing the tongue to the left. And then we need to visualize the epiglottis. Okay, next slide. Okay, then we need to place the tip of the curved blade into the vallecula between the base of the tongue and epiglottis and lift anteriorly to visualize the vocal cord. That is when we use the Macintosh. But if we use the Miller blade, we need to place the tip of the blade just past the epiglottis and lift it. Okay, and then we lift the laryngoscope outward and forward at 45-degree angle. Then we hold the ET tube on our right hand. Then we insert the ET tube into the right side of the patient's mouth. We pass the tube through the vocal cord until the balloon disappears in the trachea if we use the cuff ET tube. Then we remove the stylet. We advance the tube until the balloon is 2 to 3 centimeters beyond the vocal cord. Then we inflate the endotracheal balloon with the air, and we confirm the position of the ET tube by auscultate the lung and also chest radiograph. And then we secure the tube using the tube holder or tape. Okay. Next is about the complications of the ET tube. Okay, there are several complications. Among them are first unrecognized esophageal intubation, whereby the ET tube is being inserted into the esophagus instead of the larynx. Which, if this happens, it may lead to hypoxemia, hypercapnia, and so death. Second is vomiting. Next is aspiration, pneumonitis, pneumonia, bradycardia, laryngospasm, bronchospasm, apnea, trauma to the chest, lip, and also vocal cord, and lastly, exacerbation of the cervical spine injuries, if there is any. Okay, I think that's all about the ET intubation. Is there any question before I proceed with the IV cannulation? No, I think
No questions?
I will proceed with the.
I will ask you, it is very important.
Alright.
Number one, for neonate and small children, we are not using cuff one. Okay, the cuff 80 tube will be for slightly elder one, because the larynx of the child, of the babies, are very small, and if you make it cuff, it will cause complication of laryngeal stenosis. Okay, so it is very important. Okay, and also for medication for neonates, as a pre-medication, especially atropine, we are not using it regularly. Maybe for eldest one. Okay, because the dose of adrenaline for newborn is a bit different. But the issue which I was going to bring one laryngoscope from inside to let you see how to put it. Just a while, I will bring one and answer this phone, okay? أيوة حبيبي. انتوا Assalamu alaikum. Can you see me? So
Yes,
this is
Doctor.
the blade, the body of it, and this is the blade. We have here, you can see there is many sizes. This is 0, 0 for extreme preterm, and this one is 0 for full term, and this size 1, which can be used for a slightly big one. How to use this one? It's very simple. Okay, this is the laryngoscope. We just come here to look it. Okay, and just press. Done already. So you must make sure that the light is working and you have extra battery inside beside you, because sometimes you just put it in the mouse, everything is dim. The second thing, we must use this by our left hand. Standard, whatever you are right-handed, left-handed. Okay, so this one in your left hand. For anesthesia and like that, they used it to be very strong and you feel that they are fighter. Okay, for especially small babies, we are use this as a pen, not as a weapon. Okay, because it can cut. Its tip can cut, can cause cutting even in the trachea like that. So use it as a pen, not as a weapon. Okay, it is very important. And then, as your colleague said, I will go through the mouse. I try to catch the tongue. Okay, and go until the baby is facing me now. His head is here and his leg in the other side. Until I come and be able to see the esophagus, okay? And then I will come slightly until I can see the epiglottis. Sometimes I need to elevate. Some people do this movement is contraindicated. Must carry as all. If you did like this, you are making a trauma here, okay? So you must carry this one until you see the vocal cord, okay? So you will introduce the ET tube between the vocal cord. Sometimes it is opening and closed. So don't traumatize also the cord, because any edema here will make the extubation very difficult. So if you found it closed, just wait. When he starts to get a breath, you will introduce. Don't say open, 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 open. No. Every trauma of this, it will cause a bad laryngeal edema or vocal cord edema, which can extubate the baby, he cannot tolerate. Okay, so this is an important issue, and this one is a very, very, very important, okay, and life-saving. Okay. There is another one other than the ET tube is the LMA, laryngeal mask. Okay, laryngeal mask, it is like a pen, it will be just come to sit over the epiglottis. You need to add it because there is some babies with congenital anomalies or difficult intubation. Of course, we have now direct laryngoscope that you can use a guidance with you, okay, to see everything. It's not simple like this, but also LMA, sometimes we need it, okay? Thank you. You must know about that because this is ABC of resuscitation. You need to ask any questions? No questions?
No, Doctor.
Okay. So this is the laryngoscope. Suppose you will prepare it, inshallah, during your NRB if you are doing, if you have time to put it. Okay. Next presentation.
Next, we're moving on to the intravenous stimulation or IV stimulation. Okay, next slide. Okay, these are the general indications for IV cannulation. The first one is for drug administration. Second one is hydration. The next one is transfusion of the blood or the blood components. Next surgery, then emergency care or etc. Okay, next slide. Okay, these are the contraindications for IV cannulation. There are infection, phlebitis, clerus vein, previous intravenous infiltration or extravasation injury, burn, traumatic injuries, AV fistula, and surgical procedure. Okay, next. Okay, these are the equipment needed for IV cannulation. First, we need the dressing pack. Then we need the skin preparation, which usually we use the alcohol swab. And then we need the IV cannula. And then we need sterile shrink and the blood tube if we need to take the blood. Then we need shrink with normal saline. And then we need saline prime connector. We also need sterile IV dressing, for example, tegaderm. And lastly, we need the tapping, the splint, and also the crepe bandage for children. Okay, next. Okay, these are the peripheral IV catheters. Okay, there are several peripheral IV catheters with different colors and also gauge size. For pediatric, we usually use the blue, yellow, and also the purple color, whereby the size are 22, 24, and 22, 24, and also 28 gauge respectively. Okay, the next one, the next slide. Okay, the next slide is about the size for the IV cannulation. Okay, commonly we use the dorsum of the non-dominant hand. Next, we can use the volar aspect of the forearm. Then the next side, we can use the dorsum of the foot, and we also can use the great saphenous vein at the ankle. Okay, next. Okay, next we're moving on to the steps for IV cannulation. There are 4 steps. The first one is holding. Next one is inserting the cannula. Next is taking the blood sample, and lastly the securement. Okay, for the holding, we need to hold because we need to stabilize the limb. Okay, we may ask an assistant to stabilize the limb by holding the joints above or below if necessary. But in infant, when assessing the hand, we can graph the hand of the neonate as shown in the first picture, the first above picture. Okay, and then why we graph the neonate hand? Because we want to achieve both the immobilization and also tourniquet. As you can see, the first picture, which shows the hand of the doctor like this. Okay, that's how we hold the neonate limb. Second, we need to insert the cannula. Okay, before we insert the cannula, we need to decontaminate the skin using the alcohol swab and leave the site to dry for about 30 seconds. Then we insert the cannula just distal to and along the line of the vein at an angle of 10 to 15 degree. Okay, and then we advance the needle and cannula slowly. Okay, since we use the small vein, the flashback usually may not occur. But once we confident that the cannula is already in the vein, then we can advance the needle and cannula slowly, further about 2 to 3 millimeter along the line. And then we can advance the cannula of the needle, meaning that we just advance the cannula, the needle, we no need to advance into the vein. And then after we already advance the cannula into the vein, then we secure the hub of the cannula at the skin entry point, either by holding it down to the skin of the patient or asking the assistant to place the tape over the hub. And then we dispose the sharp needle appropriately into the sharp bin. And then the next step is taking the blood sample. Okay, for the 24 gauge cannula, it is often easier to let the blood to drip peacefully into the collection as the third picture. The second row, the first picture. That we let the blood to drip passively. Okay. However, when taking the blood for blood culture sensitivity or the gas, we need a much more volume of blood. Then what we can do is we need to aspirate the blood from the hub of the cannula. So how we can aspirate the blood is either by using the blunt drawing up needle as the picture shown. The second row, the second picture. Okay. Or using the needle and also the shrink. However, if we use the large cannula, then we can just use the shrink to aspirate the blood. Okay, that's how we are taking the blood sample. And lastly, we need to secure the cannula. Okay, first we need to remove the tourniquet before we strapping the patient's hand. Okay, and then we connect the cannula to the saline prime three-way connector at the end of the cannula. And then we flush the connector tubing with more saline to confirm the intravenous placement. Okay, and then we use the sterile tapes to secure the hub and a clear dressing over the cannula, such as the tegaderm. Okay, and then we must make sure that the proximal tip and the area of the skin around the cannula are always easily visible because extravasation injury can occur, especially if the site is not readily accessible. And then the tapes and also splinting should secure the limb proximal and also distal to the cannula while keep the thumb of the patient free. But we must make sure that the splint and also the tape is not too tightly. Okay. Okay, that's about the step of the IV cannulation. Okay, next. Next is the complications of the IV cannulation. There are several. The first one is accidental atrial cannulation. Okay, we can suspect the intra-atrial cannulation if there is bright red backflow of blood into the IV cannula. Second, if the cannula flashback appears pulsatile or there is pulsatile movement of the blood into the IV tubing. Third, if the backflow of the blood into the IV tubing, despite we use the fluid bag at the level higher than the IV incision site, and also if IV inserted in the high risk area, especially in the antecubital fossa. That's how we suspect the intra-atrial cannulation. So how we manage the intra-atrial cannulation is first, we must not use the cannula, and second, we need urgent blood gas analysis from the inserted cannula. Okay, the second complication is extravasation injury. Next one is needle stick injury. The fourth one is thrombophlebitis or infection. And lastly, unsuccessful procedure. Okay, next slide. Next slide is about the extravasation injury. Okay, what is extravasation injury? Extravasation injury is the leakage around the venipuncture site. So we can assess it. We need to assess it and we need to grade the injury. Okay, the extravasation injury can be divided into 4 grades. Okay, so we can see that in grade 1, there is pain, difficulty in flushing cannula, and then minimal swelling, and also, however, there is no redness. So you can, I think you can read by yourself about the grade of the extravasation injury. Why we need to grade it? Because the management of the extravasation injury is based on the grade. Okay, next slide. Next slide, please. Okay, this is the management of the extravasation injury. As you can see, the management are different, but the management for grade 1 and grade 2 are the same, and grade 3 and grade 4 are the same. The management are the same. So basically, if there is grade 1 and grade 2 extravasation injury, what we need to do is we need to stop the infusion, we need to remove the cannula and tape, and we need to innervate the limb. For the grade 3 and grade 4, we also need to stop the infusion. We need to remove the constricting tapes. We need to leave the cannula in situ until reviewed by the doctor. And then we need to photograph the injury. If this is not delay the treatment, and then we need to the doctor will commence the irrigation procedure within the 1 hour of extravasation by irrigating the affected area using the saline 0.9%, and then we need to give the appropriate pain relief prior to beginning this procedure because it is painful. And then we need to apply non-occlusive dressing as advised by treating medical team or plastic team. Then we need to elevate the limb And lastly, we need to refer to the plastic thing. Okay, that's how we manage the exacerbation injury. Okay, next is thrombophlebitis. Okay, thrombophlebitis is the inflammation of the vein that usually caused by the blood clot. So it is manifest by the signs of inflammation such as redness, swelling, pain, and so warm. Okay, how we assess the thrombophlebitis is by using the visual infusion phlebitis score as the picture attached in the slide. Okay, so we need to grade the inflammation. There's 5 grade. And then generally how we manage thrombophlebitis is first we need to apply the heat at the painful area. Second, we need to elevate the affected limb in order to reduce the swelling. Then we need to give NSAID in order to relieve the pain. And lastly, we need to compress the site. For example, if the site of thrombophlebitis is at the leg, then we can use the compression scaffold. Okay, I think that's all about the IV cannulation. Is there any question?
Can you tell us some more about thrombophlebitis score?
Thrombophlebitis cough. Okay, thrombophlebitis cough. Okay, thrombophlebitis cough. There are five grades. Okay, so how we need to score the thrombophlebitis is by physical examination. Physical examination. So first, for the grade 0, the IV site appears healthy. For the grade 1, there is one of the following. For example, whether there is pain at the IV site or there is redness. So if the patient has either one, there is a grade 1. For the grade 2, there is 2 of the following, whether the patient has pain, erythema, or swelling. Okay. For the grade 3, the patient has all these three signs, symptom, pain, erythema, and also induration. Okay. For the grade 4, the patient also have 4 of the symptoms: the pain, erythema, induration, and also palpable venous cord. And lastly, for the grade 5, the patient has 5 of the symptoms: the pain, erythema, induration, palpable of the venous cord, and also pyrexia. Okay, so the management is that for the grade 0 and 1, for grade 0, there is no sign of phlebitis, but the grade 1, there is possible phlebitis. But the grade, starting for grade 2 and above, there is phlebitis. For grade 2, there is early stage. So what we need to do in grade 2 is that we need to recite the cannula. We cannot use the vein anymore. And same goes to the grade 3. We need to recite the cannula, and we need to consider the general management, such as apply the heat, elevate the affected site, give the NSAID, and also compression. It also same goes to grade 4 and 5. Whereby we need to recite the cannula as one, and we need to initiate the general management.
Okay. So we came back that our top important is to define the vessel which you are going to use. Is it vein or artery? Try to define its course. Is it straight or not? How is the direction? Because our needle must be aligned with that vessel. So you need to do some pressure, especially for the vein, but a mild pressure. You are not need to make very high pressure. You need that the venous pressure is very low, 5 to 10 like that. So you need simple pressure. If you did a very strong pressure, okay, you will stop the arterial also. So no blood will come to you to the vein. So you need to make it not so hard. You see, if you press even for a while, you will start to see the vein appear. So define the course of the vein and define the length of your used cannula, where it will sit at the end, because you cannot lift the catheter in the air with a long part. It must come to the end. So if the course is not so clear in front of you, you need to come slightly far, 1 centimeter like that to break the skin and then come to the vessel, okay? This is a very important, you'll find it very simple. This is a tunnel and this is your cannula, please go and insert it. But it needs some measures, some calculation, because if the cannula is infiltrating like that, it can cause a lot of problem, as your colleague spoke about, okay? I hope, inshallah, you soon, you come and try to write for me how many skills are you able to observe and then assist and then do. And of course, between yourself, if someone is clever for one, he can tell the other, so he can also teach them knowledge. Okay, thank you. Good presentation. Let's go for the next one.
Okay, Assalamualaikum. Before that, Doctor, I'm sorry to inform, we still have 3 presenters, including me. However, at 2 p.m., we have common lecture until 5. So is it possible to take break like 10 minutes?
It is possible to finish. Okay?
Okay, so I proceed.
Yes.
Okay, so for the I will explain on the long percutaneous line insertion. So it is a long line, fine plastic tube, 10 to 30 cm long, inserted into one of the veins, usually in the upper or lower limbs, to reach a point where the vein becomes much larger, like our superior vena cava or inferior vena cava. And usually it is outside of the heart. Okay, and then the indications to allow administration for parenteral nutrition to those babies where full enteral feeding is delayed. Second, to administer medications of rates like inotropes or very hypertonic solution. Third, to those with difficult peripheral venous access. And lastly, for frequent blood taking, to avoid repeated needle insertion. Okay, the contraindications for long percutaneous line, next slide, is that infection at the site of the insertion, any cutaneous or any systemic infection, abnormal clotting factors, and the last one, non-occlusion or thrombosis. Okay, next. Sites of insertion can be on the veins at the anterior cubital fossa, long saphenous vein at the median malleolus, and one of the superficial temporal veins, but it is not preferred. Okay, next. Okay, insertion distance. So we should measure the length of the long line to be inserted prior to the procedure. If we insert via the lower limb, then we should measure from the insertion site to the xephisternum. It's meaning that from the insertion to the groin and to the xephisternum. If it is from the upper limb, then we measure the insertion site to the sternal angle. If via scalp vein, insertion to the sternal angle from insertion clavicular head and also until the sternal angle. Okay. Next slide. Okay, the tip position. Prior to its use, the location of the tip must be assessed radiologically, and it is usually confirmed by the chest X-ray in order to avoid buckling of the line. Okay, a recommendation was that all central venous line should be sited outside the cardiac chamber. For upper limb placement, the line tip should be within the distal superior vena cava. For lower, should be within the distal inferior vena cava. The example of site for position can be at the end in the cardiac chambers, in the inferior vena cava, internal jugular vein, and also subclavian vein. Okay, next slide. Okay, these are the example. On the left side is the well-sighted long line above the superior vena cava. okay, distal to the superior vena cava, and on the left side, there is insertion into the left atrium. Okay, next. Okay, maintenance of the long line insertion. The insertion should be addressed with technique, should be monitored and documented daily on the care plan with site check regularly, and minimize the frequency of the line used for infusion. Change earliest opportunity. Okay, meaning that when the patient recovered well and so on. Okay, next. Okay. There are several complications regarding to this procedure, like infection, injury to the vein or surrounding structure, accidental removal, blockage that can lead to thrombosis, embolism, heart damage. Heart damage can be involve two mechanisms. First, perforation at the time of the insertion, and the second one, slow damage to the integrity of the vascular wall, resulting in either transmural diffusion or infusion or erosion of the line into the pericardial space. And in any infant with a percutaneous long line in situ who suddenly clinically deteriorates or has a cardiac arrest, pericardial effusion, or any cardiac tamponade, it must be considered and appropriate action should be taken. Okay, next. The signs and symptoms for pericardial effusion with tamponade, like there may be bradycardia with diminished heart sounds, decreased blood pressure, decreased ECG voltage, enlarged cardiac shadow on X-ray, and this diagnosis should be confirmed with echocardiogram. Okay, next. Okay, just now Adila mentioned about class B, central line associated bloodstream infection. It is a serious infection that occurs when the microorganism and any bacteria or viruses enter the bloodstream through the central line. So the prevention step to prevent class B is to perform hand hygiene, like Dr. mentioned, apply appropriate skin antiseptic, ensure that the skin prep agent has completely dried before inserting the central line, and use all 5 maximal sterile precautions like sterile glove, wearing sterile glove, sterile gown, cap, mask, large sterile drape. Okay, once the central line is in place, follow the recommended central line maintenance practices like I've mentioned, and then wash patient also the caretaker hands with soap and water or an alcohol-based hand rub before and after touching the line, and remove a central line as soon as it is no longer needed. The sooner the catheter is removed, the less likely the chance for the infection. Okay, I think that's all for the long percutaneous line insertion. Any question?
Again, we are applying the same technique. Select the vessel, cannulate it, and now it's yours. Do you need to use it directly? Do you need to use Seldinger? Do you need to put BICC? Do you need to put central line? Do you need to put UVC, UEC? It is the same. Just define the line and do aseptic technique and follow the regulation. Don't be panic and don't be frustrated if you cannot pick vein, or sometimes the vein are very fragile. Don't be upset by that. This is the normal with working with the veins or arteries. So keep quiet and try again, but don't try unlimited trial. At certain point, you must be able to. I tried 3 or 4 times. I cannot do like that enough. I will search for other one. Don't say, no, I must be the one who did it. And you still breaking the child. Whenever anyone come after you, will not find the vein because you break the all. You cannot break the breakage. Usually, it needs sometimes to be refreshed again, okay? So take care about that. This is a common ethics which must be clear. Okay, thank you. Next.
Okay. So next topic. Procedure is about nasogastric tube. Okay, so it is a small tube that passes through the nose into the stomach for the following reason or indication. First, to decompress the GI tract. Second, to drain the stomach contents. Third, lavage of gastric contents. And any assessment and treatment of the upper GI bleed, delivery of any medication, and the last one to provide hydration and enteral nutritional support. Okay, next slide. Okay, for the preparation, firstly is to take the consent from the patient's guardian or patient's parent. Informed verbal consent must be obtained prior to the procedure and documented in the healthcare record. And then identification, properly identify the patient's name and also procedure verification. Note any patient's allergy or any adverse reaction. Okay, and perform this procedure in the treatment room in order to preserve the child's bed space as a safe environment. And then observe the pre and post insertion patient's vital sign like heart rate, respiratory rate, okay, in the BHD of patient record document. Okay, so next slide. Okay, get to nasogastric tube size for the newborns. We use the smallest size for feeding and also for the decompression. Usually for the decompression, we use one size bigger than the feeding one. Okay, next slide. Okay, to position the patient during NG tube insertion, we may need usually we need a member or an assistant to hold the child or during the insertion. And we can need distraction therapy like giving toys and so on, if available, but usually not practice. A child life therapist may involve. So we have two positions. The first on the left, we can wrap the infant in a sheet or cover as per diagram and put it in supine position with head elevated 15 to 40 degree. Second is to hold the child in a seated position. The child should not lean forward, nor should neck be extended because it can make the insertion complicated. Okay, next. Next slide. No.
Yes.
Okay. Okay. For the procedure, firstly, we should measure the tube from the tip of the nose to the bottom of the earlobe, like the first picture, and then to observe the midpoint between the xiphoid process or xiphysternum and the umbilicus. The midpoint is the tip where it should be located. The tip should be located. Okay. And second step is to next slide. Secondly, we should lubricate the tip of the tube. And then thirdly, we examine which nostril is the most patent one, and the patent one will have the best airflow. Okay, step 4 is to gently insert into the one nostril and advance tube posteriorly, aiming the tube parallel to the nasal septum and superior surface of hard palate. Okay, advance to the nasopharynx, following tip of tube to seek its own passage into the esophagus and stomach until measured marking is reached. Okay. Step 5, next slide. Okay. Where age appropriate, instruct or encourage the patient to swallow and advance the tube as the patient swallows. For infant or child with intact gag reflex, swallowing small sips of water may enhance passage of tube into esophagus. Okay. After that, we observe infant for excessive gagging, gagging, coughing, wheezing, apnea, or color changes. This may indicate the tube is in the trachea. And if it is suspected, withdraw the tube and re-advance once child is stable and comfortable. Okay. Lastly, if resistance is met, withdraw the tube 1 to 2 cm and rotate it slowly with downward advancement directed towards the closest ear. And we should note that never force the nasogastric tube. Okay, next. Okay, confirming the placement of NG tube. Firstly is to note the external length of tube at nostril. Gently aspirate a small amount of gastric fluid and check with the pH. So the aspirated content usually have a pH of 1 to 4 and is considered safe as no other body fluid naturally has a pH in this acidic range. And pH less than or equal to 4 indicates correct placement. Okay. If the child is on any acid suppressing medication or on cutaneous fluids, this range may be significantly altered. Okay. Step 3, ensure the external length of the tube remains unchanged from the step 1 and anchor with the brown tape. Okay. Step 4 is to consider X-ray prior to the commencement of fits in at-risk patient. For example, children or infant that on gastric acid pump inhibitors, on gastric pump continuous feed with diminished or absent gag reflex, and last one with an altered level of consciousness. Okay, next slide. Okay. After that, we comfort the infant. Usually they will cry, right? And dispose all the equipment according to the local standards. And then we observe, take the document all the patient's healthcare record. Note the tube type, size, date, aspirate amount, pH, and also color, as well as the type, size, and external length of the gastric tube on the nursing care plan. Okay. And then notify the relevant medical officer for any problems, like any notable fecal fluid. Okay. Next. Okay. This algorithm show that what you should do after the aspirate is obtained or when the aspirate cannot be obtained. So maybe you can read this on your own. Okay. Complications regarding NG tube, there are many, like pulmonary intubation that can lead to pneumothorax, tube displacement, and aspiration, nausea, retching, vomiting, nasopharyngeal discomfort, rhinitis, sinusitis, any nasal erosion, otitis media, noting of the tube, esophageal perforation, GERD, and also late complication can be fistula formation. Okay. Next. Okay. Contraindication and caution. NG tube insertion should not be performed without consultation with the medical consultant responsible for the patient's care in the following situation. For example, post-op period. Any reinsertion of a NG tube require following recent surgery to the mouth, pharynx, esophagus, or stomach. Non-structural abnormality like choanal atresia, recent caustic ingestion, suspected spinal injury, known or suspected esophageal varices, chronic liver disease, or liver failure. Any upper GI stricture or esophageal stricture, or any upper GI obstruction. Suspected nasal, maxillary, oropharyngeal, or esophageal trauma, suspected basal of skull fracture, and the last one, bleeding disorder. Okay, next. I think that's all from my part. Any question?
Any question? So the remaining two candidates, they have 5 to 7 minutes, and we can go through the slide after that. Okay, go for the next presentation.
Assalamualaikum warahmatullahi wabarakatuh. Alright, so the next one we will discuss on the height, weight, and assessment, and also the occipital frontal circumference. Alright, so firstly, for the length assessment, for patients of less than 2 years old, we will measure them using a measuring board, and while for more than 2 years old, we use the stadiometer or the standing height. So for less than 2 years old, usually we recommend to use to have two people or two persons, usually the parents and the medical personnel. So one will position the baby to hold on the baby, and one will measure. Then we place in supine position and measure to the nearest 100 at 0.1 centimeter. And for the more than 2 years old, so we perform without shoes. We ask the patient to take off their shoes and take the mean of 3 measurements to ensure greatest accuracy, and then we will plot on the growth curve. Okay, and then next is the weight assessment. So for less than 2 years old, we use the calibrated weighing scale. So infants will be weighed without their clothes and also diapers, and we take the measurement to the nearest 100 grams. For more than 2 years old, we use the standing weighing scale. So we ask the patient to remove their shoes and wear little clothing. And then also take a measurement nearest to 100 grams, and we'll plot on the growth chart. Okay, and for the occipital next. Okay, for the occipital frontal circumference or the head circumference. So basically we measure in children up to age 3 years old. So firstly we'll measure using flexible measuring tape. So we put the measuring tape at the maximum diameter through the supraorbital ridge to the occiput, and then we will measure 3 times and take the largest value. So we'll report the value to the nearest 0.01 centimeter, and we'll plot on the growth chart. So it is stated that there is microcephaly if there is greater than 2 standard deviation above the mean, and microcephaly if greater than 2 standard deviation below the mean. Okay, so and this measurement can be affected by thick hair and cranial bone deformation, or if patient has hyperostosis. And also to note that the height and weight should be plotted simultaneously with the head circumference. Okay, and we can measure the head circumference in older children if there is abnormal height and weight. Okay, so next is the example of the growth chart for boys from 2 to 18 years old, and the next one is for girls. So if you note that on the right there is the mid-parental centile, so that one we can plot according to the parent's height, and then we compare with the patient's height. But Doctor, I have one question. Do we have to remember this chart, the mid-parental centile, because if like it comes in exam, is it provided, or we have to remember?
Yeah, it is. It is important to plot it in the centile to set the mother and father in the like 90s or 50s or 10s, like that. It will guide us. Yes. What is the difference in color? Blue and pink.
The blue is for boys and the pink is for girls.
Very important. So you are not allowed to make mistake and put either gender in the different one. It will give you wrong reading. It happens sometimes. Okay, it is very important. The most important thing here is to able to check the crossing centile. I mean the crossing centile. If I cross more than 2, suppose I am in the 10s and now come to 25 and then come to 50 and come more, like that. So if you are crossing more than 2 centile, you must investigate.
Yeah.
You don't get it simply. Either it may be number 1, it may be wrong measures. Okay, but you must investigate. If you make sure wrong measures, so you must recheck and then make sure that it is correct. If correct, you must like the head start to be bigger and the crossing style. I mean to investigate or follow up in a shorter time like that. Okay,
Okay.
good.
All right. Thank
Any
you,
other
Doctor. So,
question for you?
sorry.
Any other
So
presentation?
I can continue.
Yes, continue.
Okay. All right. So the next one is the group chat for the preterm. So basically, the difference is the gestation age at the bottom of the graph, at the bottom of the chart. Okay. Next one is the next slide. Okay, this is the algorithm if we suspect for microcephaly. So basically, we have to confirm the diagnosis by carefully measuring again and plot the bigger of two measurements on the growth chart previously and measure the parents and family head circumference, obtain previous measurement, also check rate of growth. So if there is true microcephaly, so we'll look for symptoms or sign of hydrocephalus or racing ICP. Then if there is, so we proceed with brain imaging. But if there is no, we will proceed to the next one, which is to look for any syndromic features. So we will proceed to any like karyotyping or genetic diagnosis. And then if there is no syndromic features, so we will observe if there's any, it is associated with developmental delay. So if there is no, we will say that the patient probably there is no concern regarding the syndrome, hydrocephalus, or developmental delay. So it is said that you can consider if there is skull bone and scalp causes, or there is large head circumference in the family itself, or if there is no family history of large shape, probably there is isolated microcephaly. Okay. And then the next one is just some of the causes of microcephaly in an infant. You can read this later. The next slide. Okay, this one you can read this later. It is just some of the causes. Okay, and then next is okay. So I will proceed with hand hygiene and PPE. Okay, so as we have learned the early education of infection and prevention and control previously. So shall we do just one question actually? So can I have because we have 5 persons, so can I have each and every one of you to answer one question? So can we start with Adila to answer A? So the question is which is true about hand hygiene? So Adila, can you answer A?
True.
Okay. Soleha?
B is true.
All right. Aziza? For C.
C is for in our OT usually antiseptic, but for community usually false.
Okay. Never, we will see this later. Okay. Hanani, can you answer D?
What type of question is this? Is it one best answer?
And it's MCQ. MCQ question.
MCQ.
I think B is false.
Okay. Great. Who's the other one? Fatiha. Fatiha. Can you answer E?
E carried out at point of care. I don't really understand what is at point of care about. False.
All right. Is it? Okay. All right. Adela, can you click next so we can see the answers? Oh, okay. Dia terlari. All right. So basically, A is true. Using soap and water, and then B, alcohol is hand rub, true. And then C, antiseptic wash, true also. Because basically hand hygiene, it includes hand rub and so hand wash. So hand rub using the alcohol base, and And then hand wash, you can either use the plain soap or antimicrobial soap with water. Okay, and then de-cleaning hand by hot water, I don't think that will be true because it will just burn your hand. And then eat carried out at point of care, it is true because point of care meaning that there is these three elements that come together in which it includes the patient itself and then the healthcare workers, so either doctors or staff or the nurse, and then the provision of care or the treatment that you want to conduct. So the hand hygiene must be easily accessible to and as close as possible to the place that you are going to perform the procedure. And ideally, it is to be within arm reach. So when we perform a procedure, we don't have to run to the store or to the other cubicle to look for hand rub. Okay.
So again, the hand rub. Okay, the difference between hand rub and hand washing.
So hand rub is basically we use alcohol-based formulation. So we use hand sanitizer. And then for hand wash, we require soap and water to wash away the.
What is the difference between them?
The technique is it?
Okay, if you when you are using hand washing and hand rub.
Okay. So basically, hand wash is if we can see there's visibly soiled hand, so we want to wash it away. So hand rub usually we can use if we see that our hand is not visibly soiled, but we want to sanitize, want to clean the hand. And also when there is like available equipment for the hand wash, so it is ideal to hand wash our hands.
Yeah, it is very important. In the first instance, it is better to use hand wash. If you eat, use hand wash. If you feel that there is some dirt, use hand wash. Okay. Otherwise, we can use hand rub. But the most important to know the difference in timing also. Is it the same timing?
Timing?
Yes. For how many minutes or how many seconds I need for hand wash and how much for hand rub?
For hand rub, usually about 20 to 30 seconds, and for hand wash, it's about 40 to 60 seconds.
So it is double. Okay, so the hand rub is 50% for the time, but it must be the same technique. Okay, this is very important. I think now you need to attend your lecture. Is it at 2? What is remaining to you other than this hand hygiene?
After this, I have the chest physiotherapy and also suction.
Okay.
And then another presenter will present on the lumbar puncture, blood culture, and also venipuncture and blood pressure.
Okay, I think you can go for your lecture. What is the name of the remaining candidates? You may give in mark without presentation. Who is the remaining after you? Is the?
I'm the one after Sarah.
Fatiha?
Yes.
Okay, so I hope inshallah I can offer you time, maybe this afternoon, like 30 minutes to finish, okay? And we can just discuss about the professionality for that, okay? Hoping I can do it for you. Pray for me if time allowed, okay?
After this afternoon, is it? This evening?
Yes, it may be, I think, maybe after Asr, after at like 5 plus, we can go live 30 minutes to finish your presentation, okay?
All right.
Okay, hoping inshallah, keep in touch and hoping we can do it. Go now for your lecture. May Allah bless you.
Thank you, Doctor.
Thank you, Doctor.
Yes.
with that, or do I have to contact doctor?
Sorry? Yeah, yeah.
Check
Just contact me before
first.
near 5 to, inshallah, I will do my best to give you this 30 minutes to finish. Okay?
All right. Thank you, doctor.
You are welcome.
Thank you, Doctor.
Assalamu alaikum.
Thank you, doctor.